Master of Ceremonies for today's proceedings. Allow me to extend our most respectful welcome to our esteemed dignitaries and guests, Ms. Dr. Badru Munir, the Deputy Director for Education Research and Student Affairs, Mr. Muhammad Tiryan Sahid, the Head of Occupational Therapy Study Program, and our honorable guest speaker, Karen M. Aranha, PhD OT from the University of Zimbabwe. We would also like to extend our welcome to our designated moderator for today, Ms. Dahlia Ramadhani Ranhoran, MSOT, and of course to all the distinguished academic staff and participants here in attendance. Now, to officially commence today's proceedings, let us stand and sing the Indonesian national anthem, Indonesia Raya.
Kenapa di jalan ini sih, di jalan aja nggak apa-apa ya. Ya orang udah ada yang lewat. Iya.
Thank you. Please be seated.
Kenapa? Boleh tolong ambil HP? Oh, boleh. Ya.
We are honored to invite the Deputy Director of Education Research and Student Affairs for Vocational Education Program, Universitas Indonesia, to deliver his welcoming remarks to officially open our event. Please welcome Dr. Badru Munir. Sir, the floor is yours.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Selamat pagi.
Pagi.
Selamat pagi, salam sejahtera, salam sehat untuk kita semua. Profesor Sharon, on behalf of our School of Vocational Program, Universitas Indonesia, we would like to welcome you to our school and our occupational therapy study program. And thank you, Sahid, for arranging this event. He informed me about early last week, and that Professor Karen will be around here, and of course, as our occupational therapy slogan to go global, and it is always a precious time for us to have a lecture from international professors, scholars, and to all our students first time for us. And Professor Karen is really a global scholar. We had a brief chat before, and she works really globally in Zimbabwe, Cameroon, US, Malaysia, and often come to Indonesia. But this is the first time she has the time to have a lecture here. And as a part of occupational therapy program goes global, we always welcome to this international professor to give a lecture, to share their global experience and expertise. As you know, the needs and the demand for OT experts or practitioners in always increasing. I think and I hope we are in Indonesia. We are very shortage of OTs, so it is really a good chance, and all of you are very lucky to be or to get admitted at this program. And now most hospitals in Indonesia requires us.
Okay, next, before we proceed to the main academic session, we will conduct a brief documentation with the participants. May I request our esteemed dignitaries to step forward to the center of the auditorium, and I would also like to invite all participants to reposition themselves to the center. Excuse me, allow me to give directions in Indonesian. Guys, boleh minta ke tengah ya buat dokumentasi. Dan berdiri juga. Boleh dipakai jargonnya ya teman-teman.
Iya, lapar. Lo nggak boleh dah.
Guys, boleh maju ke depan nggak?
Boleh. Yuk. Lu yang kekecilan.
Yang di belakang boleh maju ke depan ya.
Nggak apa-apa, kesenggol nggak apa-apa nih. Nih.
Kalau di depan kan jadi nggak kelihatan. Kamu pastikan Di gigit aja tingginya sih nggak sampai.
Buat teman-teman yang di kiri boleh ke tengah ya. Yang di kanan masuk.
Lu udah ketutupan sama meja ketutup kan?
Boleh ke sini ke tengah.
Pak, sini loh.
Gua live-in YouTube-nya kan dulu. Ini aja. Dia menonton.
Okay, for all participants, please direct yourself to the camera. On count of 3, 1, 2, 3. 1, 2, 3. Oh, sign of advocacy. Okay. 1, 2, 3. Okay, thank you very much. Okay, now I'm sure everyone here wants to freshen up their minds before the lecture, so allow me to start a quick ice-breaking session called the classic game, Simon Says. So who here has played Simon Says before? Oh, Ocha has, and a few of our friends have.
In order to do that, you need to know the principles of neuroplasticity. Is that something you're familiar with? Okay, I see a few head nods, so that's good. All right, go back and refresh yourself. Refresh your lectures and all of that, because very often in the first year and second year these lectures are taught, or these lectures you'll hear these lectures, but you do not pay as much attention like you need to. But if you want to work in the area of neurorehabilitation, those principles of neuroplasticity are very important. Okay? And B, the cognitive stages of motor learning, the motor learning practice conditions. This may be a review for you, but I'll just quickly go over that. But finally, I'm going to be talking to you about use of the forced use paradigm with evidence-based strategies to help make those functional gains. So, I want you to watch this video. All right? And it's a small little video, but your skills of observation are very important. What did you see there from your clinician's perspective, or a future clinician's perspective? What did you see there? The person was walking, right? Was he walking normally? No. He was compensating, right? And so usually after a stroke, particularly if you have this kind of involvement that we call hemiplegia, a patient will feel the need to get up and move. And so when a person gets up and moves, they're going to figure out how to move, even though they do not have the skill set to move in a normal fashion. All right? But as a result, what he was trying to do is he's trying to elevate himself to advance his leg forward. What was happening to the arm? I know you can't see it from here, but you can, based on the picture, tell what was happening to the arm. What would you all call that? What's it? It's spasticity, but it's that flexion synergy pattern, right? Flexion extension synergy pattern that he's developing. All right? And so if you don't, as a clinician, go ahead and do what is right, then this is what you're going to see in your patients. Now, we refer to this as learned, known, use, because a person has had a stroke, that side of the body is not working. And as clinicians, if we are not going to focus on that, the affected side of the body, they're going to only use the non-affected side to move. what's going to happen to the affected side? Louder. I can hear you all talking, but he can't use it anymore. He's going to develop contractures, okay? And also think of balancing only on one side of your body, right? That's going to put them at risk for injuries. That's going to put them at risk for greater caretaker burden because they cannot accomplish all what they need to as far as their ADLs go. So there's greater caretaker burden. These are people that are not free to go out and enjoy community life. And so there's social isolation. And with decreased occupational engagement, there is also what we know, early morbidity or greater morbidity and early mortality. There's also greater dependence on the healthcare system. Now in the US, we've got insurance and all of that. And so, but there's only so much our healthcare systems can do, right? And here in Indonesia, just because of, a lack of OTs and a lack of PTs, a lot of your, or physiotherapists, a lot of your clients may be learning to compensate, maybe learning to move after a stroke, after a traumatic brain injury, with compensatory methods, which is not the best for improved quality of life and occupational engagement. All right? And so you have learn non-use. What does it mean to the individual? There's a decreased quality of life. Okay, there's early mobility, mortality and all that. However, I wanted to talk about the rehab team. Okay, if the person has contractures, if the person has now developed learn non-use, as an OT, it's going to be very difficult for you to help make those functional gains on the affected side. All right, and so that becomes a huge challenge. Working in Zimbabwe, I found that patients were developing these problems, but they had a lot of caretakers. However, what was happening was patients were coming to clinicians, OTs and PTs, and everyone was just stretching them without making those functional gains and helping them discharge from therapy. There was this ongoing need for therapy. So, as a rehab team, OTs, PTs, or physios, speech language pathologists, we need to work as a team and provide holistic care to prevent learn non-use. And so while I'm going forward with the pathway to help your client recover, I want you to realize that your focus should be function. It needs to be interprofessional care and teamwork with the patient and the family so that you can help your patient make functional gains. Okay, so before we move on, the icing on this on the cake is we need to talk about the benefits of tapping into positive neuroplastic changes. Okay, when we talk about neuroplastic changes, you can have negative changes, you can have positive changes. Negative changes is, let's say I have pain in my hip and I'm going to try to move and try to walk, but in an adapted way. If I don't correct that pain in my hip and I don't correct my gait pattern, my brain is going to learn to adapt to avoidance of pain. With time, I'm going to be having this, instead of moving forward, I'm going to be moving my body sideways to avoid pain in that hip, right? So that adaptation that my brain and my body makes is a negative adaptation. A positive adaptation is, yes, we have the problem, but let's treat the problem and let's now try to engage your client in normal movement. Okay? And so this positive adaptation particularly for that 40% that come to us for therapy, needs medicine, it needs neuroprotective, good nutrition, it needs enriched environments because, like for example, if you're going to have steps for a client who's had a stroke right at the very beginning, they're going to adapt to those steps because they cannot advance their foot, right? They may be doing furniture walking. However, an enriched environment for someone who's had an early stroke, who's had an acute stroke, may be avoiding putting that patient in that situation. And it requires the help of clinicians to guide families, to guide clinicians. So in terms of that positive adaptation, you need medicines because there are medicines that help with improvement, increasing of neurotransmitters and all that help with neurogenesis. You definitely need certain foods. Now, do you get blueberries freely in this country? No, blueberries? Blueberries, yeah, no. But anyway, so there are certain foods that help increase, that protect the nervous system. So one of them is turmeric. I know you'll drink your jama. Yeah, that's supposed to be very neuroprotective, okay? Salmon, eating fish with omega fatty acids is neuroprotective. So encouraging your patients, educating your patients on these kinds of foods will better help their recovery process, okay? And also as for you young people, and eating those kinds of foods will help you in the long run, okay? All right. And then, of course, giving them the right exercises and the right kinds of therapy to help with the recovery process. So the benefits that we're going to see with the right therapy, okay, is important for us to think of because all of you all have heard of constraint-induced movement therapy, right? Okay, constraint-induced movement therapy gives you those functional gains, but you want to make sure those gains are seen at least 6 months to a year post-therapy, after their discharge from therapy. This tells us that that positive adaptation, the neuroprocessing in the brain has taken place. All right? Now, what's important to also realize is these skills that are acquired become automatic. If you're teaching your client, and I'm going to use gait just because it's easy for me to demonstrate. If I'm going to teach my client to use, let's say my right side is affected in a more normalized way, right?
Right.
Initially, the patient has to use a lot of their energy trying to figure out that gait pattern. But if you're going to engage them in repetitive task practice, those functional ways of engaging that affected side, this is going to become automatic. They're going to require less of their cognitive energy to focus on how to engage in that movement, okay? So you want the skills to become automatic. You want the skills to become generalizable and transferable. So I'm using my skill to walk. However, eventually that reciprocal leg movement, we should be able to now climb stairs. We should be able to get in and out of a car. There are all these skills that we develop that need to be now generalizable and transferable. And in a minute, I'm going to talk more about this. Okay? So this becomes meaningful to the patient, but also, have you heard the term occupational synthesis? No? Okay. So if you get the patient to a point where the basic skills that you have taught them becomes generalizable and transferable, we say they've reached a point of occupational synthesis. And as OTs, we want to see this. Okay? Generally, when your patient is ready for discharge, they need to be at that phase of generalizable, transferable, and occupational synthesis. All right? And of course, the last bullet is improves health and quality of life. Okay, so that's just the basics. Now I'm going to talk to you about the pathway to promote engagement in occupations post-neurological insult, okay? And so one of those things that I feel like is absolutely important is you need, as a clinician, to have the skills. So, kinesiology, have you already done kinesiology? Okay, I heard a yes somewhere. On the other side, I saw some no, head nods which said no. Kinesiology is absolutely important if you want to go into, well, even orthopedics or neuro, or even the in pediatrics. Very often I hear OT students who feel like that's just too much kinematics and kinetics and do not pay as much attention. But if you want to help someone engage in and move in space, then understanding kinesiology is very important. So I put that out there because you're still students and it's not too late to go back and refresh your memory on kinesiology and anatomy, okay? You need to have good observational and analytical skills. Looking at the patient that I just showed you a little while ago, even though it was so brief, immediately you should be able to pick up on things that an OT needs to address. And that happens with observation. Yes, we're going to do a full-blown assessment and all of that. But your observational and analytical skills are important to understand what is it that's limiting that movement, okay? You have to be creative and have good problem-solving skills. A couple of years ago, I visited Bali and I went and visited an occupational therapist. And all she had in her clinic were coloring books. Now, I understand in countries, and it happens in the US also, we don't have all of the equipment we need. But given the limited equipment we have to learn to be creative to help with our skill acquisition. Okay? And so one of those activities that we do very often in the US is we give them a ball or we give them some little object and we say, okay, how are you going to use this in therapy? So you've got, not only do you got to do a task analysis, but you also have to do an object analysis to see how to apply, use that equipment, the limited equipment you have in therapy, okay? You have to keep up with evidence-based practice. Professor Chai and I were just talking that when we met at the World Federation of Occupational Therapy, clinical practice is 20 years behind research. All right? Sometimes in the global south, it's more than that, but that's all right. I think from moving forward, if we can focus on making sure we understand evidence-based practice is really important because evidence-based practice is showing us the future on helping people with neurological insults make those functional gains and recover more wholly and completely. All right? You also need to have a willingness to invest in time and effort. With musculoskeletal disorders, you can just give them rote exercises and patients will gain strength and gain coordination and all of that. With neurological problems, sometimes it takes months, sometimes it takes years. And so you should be willing to invest that time, but also the effort. Getting a patient up who cannot sit up at the edge of bed is a lot of work. And very often my patients my students who do not exercise or keep, go to the gym and stay conditioned have a hard time coping with the rigors of being a neurorehabilitation therapist. So taking care of yourself and investing in time and effort is very important, okay? And finally, I've already spoken about that interprofessional piece, which is very important. Okay, so, I guess I'm not pressing the right thing there. Okay, now you need knowledge. So this is the next few slides. I'm going to talk about neuroplasticity. I'm going to talk about motor learning, and I'm going to talk about some evidence-based strategies. All right. So with neuroplasticity, does this look familiar to you? Because I don't want to repeat what is already said here. Okay. So I'm seeing head nods. So there are about 10 or 11 principles of neuroplasticity, and they're all important. Okay. However, I do want to emphasize being specific. Okay, training the experience, if it is right hemiplegia, right? Focus on the right side of the body. Be specific in what you're doing is important. Repetition is essential. And when you're teaching them, getting them to repeat it over and over again in the right way is also very important. Intensity is important. You know, how long do you see your patients for therapy in this country? 30 minutes? What do you say? 45 minutes? Okay. So, and that may be 3 times a week, private clinic, twice to 3 times, right? So with your stroke patient, particularly in acute care, but particularly in subacute, where they've just had a stroke, they just had a traumatic brain injury, 5 times a week, 75 minutes is what you need to focus on if you want to see good results. Okay? Now, I understand your healthcare system may not allow that. However, you can get family involved, you can get friends involved, and you can give them home activity programs that can make up for that time that you cannot quite spend with the patient. Okay? All right. Age matters. Pediatric patients, younger the adult, the better condition the adult, they are going to recover faster. Older adults take longer, and you have to be more creative. Okay? Notice that the word transference comes here. Okay? So I want to emphasize the importance of transference. Okay? I am going to get from sit to stand. All right? What am I working on? I'm sitting and I'm standing. What am I working on?
Flexi extension.
How would you describe that? Or how would you call that in one word? Okay, I'll tell you, a squat or a reverse squat, because it's hard for you to get into my mind to figure out what I want, right? So a squat or a reverse squat, that's the basic unit that I'm working on. Now, when you're looking at ADLs, we're talking about transference. What ADLs do you need? I mean, in what ADLs do you use that squat? Besides sit to stand? Toileting? But again, toileting, we're talking about getting down to the toilet and getting up to stand. So that's still sit to stand. I want you to think of other areas that requires that squat. What did you say, sorry? Excellent. Yes, you're bending down to pick up an object that requires a squat, a deep squat. Okay? Think of pulling up your pants. You get your pants up towards your leg. You're doing a squat to pull up your pants. So, in the clinic, you may be teaching them how to get from sit to stand. All right? However, there are benefits, but once it becomes automatic, once they've engaged in this task multiple times, they should be able to transfer that basic unit of a squat to engagement in other ADLs. That's what I mean by transference. All right? The other thing I want to talk about is interference. You teach your patient how to do something, now they go home and go back to their old ways of doing things. That's interference. So you have to teach them to engage in a task the way you want them to engage, and then they need to go home and make sure they're practicing it. So their repetition comes into play, because once there's interference, those motor now are affected. Okay? So patient expectation, you need patients who are really interested in doing what they need to do. And so that's where that mind-body occupation, that mind-body bridge happens. Because if they're really interested, if they're really invested, they're going to do more of it. The family is going to be supportive and they're going to make progress. Now, there are patients who at the very beginning are not motivated, but it's up to you as a clinician to get them motivated. And as OTs, what do we call that? When you're trying to motivate your patient to get better. Therapeutic use of self. You'll have heard that term, therapeutic use of self. You work with that patient, with the family, support them, make sure they understand this is all done in baby steps and motivate them to get better. Okay? All right. So, patient expectation, feedback. Your feedback that you give the patient is really important. In a little bit, I'm going to talk more about feedback. So, you need to be actively engaged. Now, I've been to countries where they just put patients on machines and therapists are on their cell phones or talking with other therapists. All right? With neurorehabilitation, that does not work. You need to be there 100%, giving them, either observing them, encouraging them, giving them feedback on their performance, because that encouragement is really important. Okay? And then, of course, it needs to be fun, because then they're going to look forward to coming and look forward to actually exercising. And then helping others also, I think, is they don't need to look inward and feel sorry about their condition, but they should look outward and try to help other people, and that decreases the stress in their life and helps them further progress. Okay? So those are the principles of neuroplasticity. Have you spoken about the stages of cognitive learning? No, not yet. Okay. So you're going to get a head start, because I'm sure when you go to rehab, they're going to be talking about this. So you know the principles of neuroplasticity, and as you work with your client, you want to make sure what stage are these clients. Initially, when they're first learning a skill, they're at the cognitive stage. That means they're just learning the rules of what it takes. Like, for example, a squat, right? They're understanding they have to go lean forward. They have to engage in that anterior pelvic tilt. And they have to keep leaning forward till they actually sit down. Okay? That's very difficult for someone with a stroke. And so they are at a cognitive stage. If they can come to your clinic the next time and they can repeat that skill, then they're at the associative stage. Okay? Notice that at the cognitive stage, you need to be working more with your client, giving them a lot of feedback, a lot of handling, all of that. Now, once they reach the autonomous stage, that's where they are at the transferable and the generalizable stage. Okay? So these are the three stages. Fitz and Posner came up with three stages. Carr and Shepard came up with similar stages. So you may hear these terms and they're interchangeable. But as a clinician, for you to give them the right amount of help, you need to know what stage they are in. So you can give them the right amount of exercises and the help so that they can advance from one stage to the other. Are we good with that? Okay, so that's important. Then we have the motor learning practice conditions. Are you all familiar with this? No, okay. So in order to advance your client from the cognitive stage to the autonomous stage, you need to take them from part versus whole. So initially working with all of those ADLs may be very difficult, right? Like dressing. So initially you may just teach them putting their arms into a sleeve, and you may do the rest. But gradually you build on that, and then by the time you take them to the end of discharge, they should be able to engage in the whole. All right? The next thing is block versus random. Block is the same thing over and over again. Random is now when you change the exercise. So let's say block, I'm getting my client to work on picking up garments from a closet. So I'm going back and forth and I'm getting them to do that over and over again. But what is the function I'm working on there? When I'm reaching into a closet to pick up a garment, what is the movement in kinesiological terms? What is that I'm working on? Shoulder flexion, exactly, okay? Now, there are other functions that require shoulder flexion. So initially, I'm in one place working on this shoulder flexion. By the time I get to random, I should be able to have them engage in shoulder flexion when they're batting a balloon, or or combing their hair or, whatever function it is, they should be able to engage in that shoulder flexion. Okay, so that's block versus random. We have distributed versus mass. Distributed is when you are your client is resting more than they're working. Okay, in acute care, when a client is very weak, they may need to rest. They cannot go on for 75 minutes or even 45 minutes. So you're giving them a little bit of exercise, you're stopping and resting, and then you're continuing with your therapy. While they're resting, they don't just have to sit there and not do anything. You can work on mental practice. You can work on sequencing. You can work on things like that because you're building your client for this time that they're there. Okay? So that's distributed versus mass. Mass is when they can work for 45 minutes at a time without stopping. All right? Then you have constant versus variable. In the clinic, you're going to be teaching them dressing at the edge of bed. By the time they get home, they need to be able to dress wherever they are, whether it's a toilet, whether it's in their living room, wherever it is, they should be able. So when we talk about constant versus variable, it's the context. All right. So every one of these motor learning practice conditions, at the beginning cognitive stage, it's very simple. By the time they go to the more advanced level, you have a different criteria for them, for your client. All right? Let's go to feedback. This intrinsic feedback versus extrinsic feedback. Intrinsic feedback is when I'm working with my client, getting them from sit to stand. Just the movement of getting from sit to stand, now they're understanding what they need to do. Are they doing it right? You may be giving them tactile cues and all that. That's intrinsic feedback. Extrinsic feedback is when you're talking to them. Okay? You have knowledge of performance, knowledge of you give them knowledge of performance while they're in the act of doing the activity. Knowledge of results is after they finish with their exercise. After they finish with the activity, you're going to tell them, well, that was good. However, maybe you took a little extra time. Next time, you got to be quicker. Okay? Now, I'm not sure how it happens in Indonesia, but in the US, we have to document all these things. So all this terminology to show our insurance company that we are engaging in evidence-based practice, this information is all very important, okay? So now that you've heard this terminology and you're practicing on your documentation, writing SOAP notes and all that, try to utilize this terminology, okay? And finally, we have guided versus exploratory. In the beginning, you're going to guide your client. As they develop skills, they're going to now explore. Okay? We have particular ways of teaching them to dress up, getting out of bed. But once they've developed enough skills, they should develop their own identity of how they want to engage in that exercise. And so you take them to that exploratory phase. Okay. Finally, and I'm sure this is a long lecture, so Ms. Chaya, anytime you want me to stop, tell me to stop because normally all what I've put into one lecture, I do it over a semester or, longer, okay? And also we have practicals, so just bear with me. We have to have time for discussion. You can talk to me and we can ask questions and then I can also demonstrate, okay? So with evidence-based practice, right? I've told you what the cognitive stages are, what motor learning practice conditions are, but I think it's important for you to realize that as clinicians, you want to use the forced use paradigm. The forced use paradigm will help that affected side recover. Okay? So what you have observed in clinics here, what are your thoughts about therapy with people who've had strokes? Are they teaching them to compensate or are they using the forced use paradigm? Have you visited clinics here? The third year students maybe? Oh, year one, but year two also no? Oh, okay. All right. So the old way of doing it was compensation. We taught them to compensate. But now the focus is on forcing the affected side to regain function. And so what we use is a forced use paradigm. Okay? We have constraint-induced movement therapy, which is evidence-based. And you'll have heard of constraint-induced movement therapy, but you've not utilized it as yet. I mean, you've not been trained on it. Okay? And what we have found is that the benefits of constraint-induced movement therapy happens 6 months post-discharge. You still see the benefits. You also, they have found out that we have a certain neurotransmitter called brain-derived neurotrophic factor. So anytime you exercise your client using the CIMT, there's that increased neurochemical in your body that helps with those neuroplastic changes. Okay? And so while CIMT is is evidence-based and is good, the problem is you have to meet certain criteria to use CIMT. People need to be ambulators. People need to have about 10 degrees of finger extension, wrist extension, and all of that. Not all of your clients in the acute phase have those abilities. So a lot of them don't qualify for CIMT. The lady that I have in my PowerPoint, she is pretty functional, and I couldn't do CIMT with her because of the protocol was making it too difficult for her to use CIMT. All right. So there are lots of challenges. So as OTs, we need to acknowledge that, yes, it's a good evidence-based practice. However, we need to acknowledge the challenges and see how we can help our clients. Okay. So in order to be able to get your patient to using CIMT, you need to be able to do preparatory activities. You need to be able to do simulated activities. And finally, you need to engage them in occupational engagement. Okay? And so I'm just quickly going to go over the preparatory activities. For preparatory activities, you use neural flossing to help with neurodynamics. Is that a new term for you, neural flossing? Yes? Okay. I'm not even going to go into the detail of neural flossing because that may be a lab and that may be more in a practical course later down the road. But neural flossing is a technique that we utilize to help with the flossing of the nerves, to help with neural messaging. Okay? Once we do that, patients actually, like for the median nerve flossing, you all know the median nerve, right? The movement is this here. We go into elbow extension, wrist extension, finger extension, and we get them to bend their elbow, straighten the elbow. They get the feel for what it is like. All right? And so neural flossing, you have median nerve, ulnar nerve, radial nerve flossing, which is very important. Notice also, well, that's in my next slide, so I think I'm going ahead of myself. Something else that we need is alignment. What happens once you've had a stroke? To alignment.
Jawabannya.
I'm talking about the musculoskeletal alignment. What happens when you've had a stroke? Are you symmetrical?
No.
You lose that symmetry, right? You lose that alignment. Now, as an occupational therapist, if you're saying, oh, come on, let's get dressed, let's get out of bed, when the body is not in alignment, how can the muscles work? Right? In kinesiology, you're going to learn that you need that alignment because our body is a system of levers. So, addressing alignment before you go into engagement in occupations is really important. Okay? And so we do joint mobilization. Okay? And then finally, we have strategies to increase that brain-derived neurotrophic factor, because if you want neuroplasticity to happen, we definitely need to improve or increase brain-derived neurotrophic factors. Okay? Now, how do you increase brain-derived neurotrophic factor? Well, one thing I've told you about the food. All right, food that we mentioned increases the BDNF. You also listening to music, mindfulness practices, aerobics, all of that increases brain-derived neurotropic factors in the system. Okay?
Okay.
If you have increased BDNF in your system, there is the process of neurogenesis happening in your body or in the patient's body, which is of benefit. Okay, so I knew I was going everything, but we've already spoken about alignment so that now you can encourage your patient. Now you can encourage your patient to start moving or help your patient to start moving or help your patient to start moving. Otherwise, they're going to have problems. Okay? You also have lumbar mobs, pelvic mobs, and lower extremity mobs. Okay? Here in Indonesia, do OTs do anything with the legs? You'll work with the legs, not so much. Okay. All right. So, but remember, after a stroke, this is what the foot looks like. So if you're teaching your patient to stand in front of a sink and groom themselves, if you don't do mobilization of the foot, they do not have a proper base of support, right? So while as a discipline, we decided we're going to take care of upper extremities and PTs are going to take care of lower extremities. It's important, the times are changing. It's important that OTs also understand the lower extremities and understand how to mobilize it so that when they're engaging in ADLs, they're feeling more comfortable. They're feeling more like, yes, I'm getting something out of this intervention, okay? And if you don't do it, what's going to happen is while they're trying to use their upper extremity, the lower extremity is going into spastic movements. What is happening to the upper extremity when the lower extremity is experiencing spasticity? The upper extremity is also going to experience spasticity. And that's the same with when PTs are walking a patient and they're not paying attention to alignment. Now upper extremity is going into that flexion contraction. Okay, so both OTs and PTs need to work together, and it's okay to duplicate services because more is better than less. You want to help with functional gains, all right? Particularly in this condition. All right, so just restoring alignment is not important enough. You have to start working on functional gains. Okay, so simulated activities, you'll have heard of the task-oriented approach. Yes, no?
Yes, yes.
Okay, as a clinician, you're always going to see what is the task, what is the individual's capabilities, what is the environment like. This is not the PEO framework. This is called the task-oriented approach, okay? And so with your individual, you want to look at what are their sensory motor capabilities, what's cognition like, what's perception like. With the task, you want to see what stability requirements, what are the upper extremity manipulation requirements, lower extremity mobility requirements. Because what's going to happen is you're going to be tweaking the environment to make up for the issues that the patient may have and may not be able to engage in the occupation. It's only when you address the task, individual, and the environment are you going to see movement and occupational engagement. And as a clinician, you're using this technique, the task-oriented approach, every minute of your day as a clinician, whether you're working with an orthopedic patient or you're working with a neuro patient. Okay? All right. Really quick because how much time have we almost 15 minutes?
Yeah.
Okay, so about 15 minutes. So I'm just, have you all spoken about NBT or BOBAP? Maybe not yet, done BOBAP? Okay, so one of these treatments, BOBAP, PNF, RUDE, okay, were treatments that started in the 40s and 60s. And there were some benefits to it. But now as we're going through, as we're going through time, very often they say, oh, those techniques are not evidence-based. And so in the US, they almost discourage you from using those techniques, and same in Europe. However, we can't throw the baby with the bathwater out. You've heard that phrase? You just can't, just because the bathwater is dirty, you can't throw the baby out as well. Okay? There are certain benefits for these techniques, and we still utilize them. And so I'm just going to mention them to you right now, but I'm not going to go into detail because it's just going to waste your time if you've not had a lecture on these techniques. Okay? So neurodevelopmental treatment requires positioning. It teaches you weight bearing, weight shifting. It teaches you to actually put weight on that arm, the hemiplegic arm, to try to decrease the tone in that extremity so that you can work on the muscle imbalance. Same with the leg, okay? Arm and leg together. You need to learn that we need, which this may be something you already know, we need proximal stability for distal mobility. You've learned that idiom? Yes, okay. So if your client cannot sit up in bed, doesn't have posture control, don't go into ADLs like dressing and all of that, because it's a waste of your time and waste of your patient's time. And and I'm going to give you a case scenario which actually happened in my clinic, where this OT was working on a patient on dressing lower body when she couldn't sit up in bed, at the edge of bed. And the therapist was getting frustrated, and the poor patient was trying to go on with the program. And finally, the therapist came to another clinician and said, I'm not sure what I'm doing wrong, but I'm not being successful. Good thing that the therapist did that, because the next clinician took over the patient, worked on posture control, and once she developed posture control, she then worked on dressing. Okay, and this patient went home and lived with her grandchildren for 3 years after that. If the therapist had continued with dressing, lying in bed, this patient would have never reached a point where she could have gone home. She would have gone to what we call a nursing home in the United States, which is a place for it's called an old folks home. Okay, so we still use these techniques, body on arm and body, and all of that. And what's really important about NDT is we've got what's called handling techniques. We have points of control where, for example, I'm just going to show you right here. I can put my hand on the sternum of the patient and get them to bend. I can get them to extend their spine. Okay, so we've got these points of control throughout the body, and by using our points of control, we can teach our patients to move in space. And we've got all that information from NDT. Okay, and this is about handling. And so I'm just going to skip that. Let's go to PNF and Root. Okay, with PNF, the people who advocated for PNF believe that all our movements are diagonal patterns. And so we have, when there's spasticity, we can do little circular movements with the digits and decrease tone. I'm just quickly going to show that to you in Ms. Chaya, because this is a technique that you will need to use when someone has spasticity. So let's say if our fingers are curled, I could pick a finger, I would go into circular motions like this and straighten it out. And that's called rhythmic oscillations. That's a PNF technique. Okay? Now there are other techniques that we can, I'm not necessarily going to touch on, but PNF also has some very valuable techniques that you can use for skill acquisition. Okay? With Root, her techniques were primarily on facilitation and inhibition. When there is tone, how do you inhibit tone? If there is no tone and just facility, how do you facilitate tone? And there are several techniques that she gives us that are very helpful. Now, one other technique that I think was very valuable was modulating the nervous system. Now, with the nervous system, you've heard of parasympathetics and sympathetics. Is that familiar? Okay. So what happens when you got the sympathetic nervous system that's in hyperdrive? What is it? Excellent. Okay. Yeah, she's got it all. Okay. So you're in the fight or flight mode. So when your patient has a heart rate that is up, who's anxious, adrenaline level is up, they're not listening to you, right? If I am talking loudly to a patient who's in a sympathetic hyperdrive, will that function? Will that work? It's going to make them more anxious. So what would I need to do? I would need to calm my voice and talk to that person gently so that I bring that sympathetic nervous system down and help the parasympathetics improve. Okay? And Root gives you several techniques on how to get that balance going in the autonomic nervous system. Okay? All right. So something else I use are props to help with therapy. So let me see if I can, no. You see, I want finger extension. So I'm using a ball for her to roll, gain that momentum, and get that finger extension. Okay, those are called props that we use in therapy. Here, I'm using a ladder to help the patient stand up and work on standing posture and balance. Now, I don't think that even in the US, you don't see the ladder being used very much. However, the ladder, things like balls and all that are very good props to use in the clinic, and you can easily get these things. Okay? All right, moving on, mirror therapy. Let me put all this there. Okay? I'm not going into the details, but I've given you lots of resources where you can listen to YouTube videos and understand how mirror therapy is used. These are all the different things that mirror therapy taps into, okay? And for the sake of time, I'm not going to go into detail, but I'm just going to kind of tell you what I have in my PowerPoint that you can then go and watch, either read up or watch videos, okay? All right, bimanual techniques. All of you have done neuroanatomy. We have the right brain, we have the right brain, you have the left brain. The two parts of the brain, the two hemispheres communicate. Which is the structure that helps the two hemispheres communicate? The corpus callosum. Okay? So using bimanual techniques, like you can see this young man here with the ball, getting him to go into elbow flexion and extension, right? We're getting the non-affected side to lead while the affected side is learning the movement. When we're using the underlying mechanism that the two hemispheres communicate using the corpus callosum. Okay, and that's called bimanual techniques. Now, this is a simulated activity. If we are engaging in an occupation, what could be an occupation that you could utilize to teach bimanual techniques, or rather use bimanual techniques for an occupation? Go ahead. I think you're saying something. You? No? How about taking a cup to your mouth to drink? Okay? Again, you need to have a good understanding of occupations so that you can apply these techniques, whether it's a simulated activity or it's an occupation. Okay? All right. Moving on, action observation. I want you to watch. Oh, sorry. Wait, give me a second here, okay? I'm asking the patient to give me the lotion she has in her hand. And ordinarily, and her way of giving to me is like this, okay? Sorry, it's taking a little longer here. There you go. That's action observation. We have mirror neurons in our brain. Now, I didn't need to go into too much of an explanation, But by just getting her to use the non-affected side to engage in the movement, she understood the rules of that activity. And that's called action observation. Okay, so those are techniques you can utilize. Then we got a condition, and you'll have probably heard of the condition of heavy neglect. Have you? Not yet? Okay. When you have a stroke, sometimes there are patients who just ignore one half of their visual space. They're out there. All right? And generally it's the left field. Now, the lighthouse strategy teaches them to scan their environment. You may use anchors and say, an anchor could be a colored strip or something, and I'll say, turn your head till you see that red strip. So I'm teaching her to now access that space that he or she may be ignoring. All right? And so what we do is we use the lighthouse strategy to help with that hemi neglect. And so I have given you literature there that you can actually utilize to understand the lighthouse strategy and utilize it and use it. Oh, sorry. So, wait. Okay, so finally we've got the forced use paradigm, okay? The forced use paradigm is where we're using occupations. All this time is preparatory simulated activities. Now we're talking about occupational engagement. All of these techniques that I have, strategies that I've mentioned here are all evidence-based practice, okay? So with constraint-induced movement therapy, this is the criteria you need to qualify them to be in, to use CIMT. And so the patient needs to be pretty high level. Once they qualify, you want to engage them in repetitive task practice. While they're engaging in repetitive task practice, you want to put their non-affected hand, oh, sorry. Give me a second here. I've got lots of videos. Where am I? Oh. Okay, let me keep talking, okay? So with CIMT, you have to put a glove on their hand for a certain number of hours in the day. So it's usually about 6 hours in the day while they're practicing on using their affected arm. All right? So can you see the forced use concept being used here? Okay, while Ms. Chaya takes care of the PowerPoint, I want the rest of you to listen to me, okay? So you also want to sign a contract with them and give them a motor activity log. So when they go home, whatever you're doing in therapy, they're practicing at home. But they have to work on putting that mitten for 6 hours in the day, and that's what makes it very difficult. Because now the only arm that is working, you're putting in a mitten and telling them, okay, you can't use this arm. All right? So a little bit of history about the CIMT. In 1983, there was a researcher by the name Levier. He caused rats to have a stroke. And then he tied up the good side, and within 17 days, the affected side recovered function. But we can't do that with human beings, right? So we use the mitten to kind of, use the forced use paradigm, okay? What was the next thing? So that was CIMT. Excuse me. So the repetitive task practice, and all of you may have your PowerPoint, which I shared with you earlier this morning, which Ms. Chaya shared. So repetitive task practice, I've given you the protocol. It's repeating the same thing over and over again, okay? So we've got repetitive task practice. What else do we have there? You have task-specific practice. By the name, you know what it is. Another technique that's really good is errorless training. When your patient is scared, when your patient is nervous, engaging in errorless practice training is really important. Now, for each one of these techniques that I've talked about, I've given you resources. Okay, so go back and look at your resources whenever you get to the application part of your course, because these are all valuable techniques that you can utilize. Oh, okay. And it's almost, give me a second here, almost looks like I'm running out of time. Okay, that's the aerial strategy training, and you see I've got links as well as citations, okay? Now, our goal is to bridge mind, body, and occupations, okay? And I've got this case study that I have of a 72-year-old patient, and right now she's 4 years post left CBA, but she came to me with dense hemiplegia, okay? And so her right upper extremity was positioned in a Gilmore sling. Now, she had gone through the regular rehab process and they discharged her because she was independent, because she could use her non-affected side to dress herself. So this is how she looked like, okay? And these are short videos, so I can just quickly play them. See how she is moving. Her gait pattern is pretty good because that's how we had trained her to move, okay? I want you to look at her thumb function or hand function. Sorry.
Belum.
I put 3 videos in a slide and so it's not. Okay, so we finished with that. Let's see if this next one works. No, it's not. Okay, let me explain to you what you'll see. Okay, they're videos. So with this second video, I'm getting her to extend her thumb and bring it back in, and she has trouble doing it. Okay, but look what I'm using. I'm using the edge of a table, a prop. I'm giving her a target. I'm getting her to come out and in. Here, I've given her a ball, and I'm getting her to roll the ball into her palm because I was trying to get her to curl her fingers as well as extend her fingers. All right. So I gave her exercises so that she could work on dexterity. All right, look at the finger extension, right? Would you call this a simulated activity or would you call this an occupational engagement? It depends, right? This lady was a Buddhist, but in Islam, don't you all also pray with your beads, right? So you could use it as an occupational engagement, but with this lady, it was simulated. But what I wanted was a thumb extension to happen, all right? And then here, let me see if I can get this. She's going there. Okay, watch this. I'm getting her to pick up beads. Again, this is a simulated activity. And this was a lady who had dense hemiplegia, so I'd done all of the preparatory activities, okay? So what I'm working here in this corner, this last slide, is I'm working on ulnar stability. If you were going to write, what happens to your 2 digits 4 and 5? They have to curl in. And as an OT, you need to give them exercises that will bring those fingers in. So this exercise that I'm giving her there was to help with her ulnar stability. Okay? Let me see if this works. Okay? I'm teaching her to do stairs. Walking backwards was a lot easier for her because she did not have the fear of falling forward. Okay, and so you can see her on this this slide here, coming down the stairs. Watch where my point of control is. It's on her pelvis. Why do you think I'm using the pelvis as a point of control? Where is your center of gravity? It's in the pelvis. Okay, so if you're losing that center of pelvis, the patient is going to fall. So you always want to have, when you're working on movement, your hands on the pelvis. All right? Now let's see if this one works. Oh, wait. So I'm trying to get her now looking down at the stairs and see how difficult it's becoming for her. Okay, that first step was hard. And my student right here is also nervous. See how it becomes easier and easier for her. Okay, now in 2023, I'm going to stop that and we're going to go on to her mowing her lawn. Okay, that could be occupations and means, occupations as in. So we're working on balance, we're working on that foot mow control and all that, but eventually she's able to actually mow her. Now, this was a picture she just sent to me a little while ago. She's actually sewing. Look how she's got her fingers all open. I don't have a video to show you, but this is the functional level she's at. Okay? And I wanted to show you this one because this was a lady who was very interested and into yoga, but when she had a stroke, she couldn't do it. Doesn't look like that video has.
Put it even to the plate.
Okay. So that's just to show you how we use the neuroplasticity principles, the motor learning practice conditions, the preparatory activities, all of that to get her to this phase in her life. And in fact, at the end of August, she's coming to visit me in Bali. Yeah, but she's also now traveling, right? Okay. So that's all I have. Do I have time for parting thoughts or should I stop?
I think we have a question and answer.
Okay, let's go into question and answer. Okay.
Okay. Thank you so much, Ms. Karen Aranha, for your very insightful presentation. I invite you to have a seat here, and we will have a Q&A session.
Okay.
I think it's about for 20 until 30 minutes.
Okay.
For me personally, it's also quite insightful because some of the things I never heard, right? Even I already become OT, a practitioner, but it's the first time I heard about that. So thank you so much. And I think also for the student, we all have a question that inside our head. So please, for all the students, if you have something to ask for Miss Karen, it's time for us to learn more from Miss Karen. Okay, maybe for waiting, waiting for the students to thinking about the question, I would like to ask, because I'm personally curious about one thing. You mentioned about OT is actually not only like the upper body is for OT part and lower extremity is for PT part. Meanwhile, in here, we still have that kind of stereotype. If the patient goes into a clinic or hospital, then the hand part will be the OT, but the foot will be the PT. So I was wondering how to differentiate between if OT want to work on the lower extremity part, also how to differentiate the role of OT in PT on that case.
Okay. Good question. So I think you first need to go back to the history of why OT was given upper extremities and PT were given lower extremities. So after World War II in the United States, soldiers were coming back to the country disabled. And so to make things easy, the government said, all OTs take care of upper extremities and PTs take care of lower extremities. That was the history, at least in the United States. I do not know if that's what has caught on the whole world over. Okay? But the more we are understanding about neuroplasticity, you have to treat the whole person. PT cannot say, I'm only going to treat legs. PT needs to take care of the arms because if the PT does not take care of the arms, the OT, the patient comes to you with their arm tight. Okay, so they have to learn techniques to keep their arm relaxed. And the same token, OTs cannot wait for the PT to work on lower extremities because we do lower body dressing. We do a lot of ADLs that require standing and moving and all that. In fact, everything that we do requires the use of lower extremities. Now, how do we decide what is OT and what is PT? OT's goal is to improve balance, gait, and functional mobility. OT's goal is to improve independence in ADLs. So your goals will decide what your scope of practice is, what you can do and you cannot do. If you're working on lower body dressing, then you should be able to address lower extremities. You should, now in low body dressing, I can put on my pants sitting at edge of bed. But I may also decide if the patient is very young and can do it, I may teach them to stand up and tread their legs into pants, right? So just like single limb support, like standing to move is important for PT, it's also important for OT. So OT, your goals are going to decide what you need to work on. Now, I don't write a goal for gait, but I do write a goal for dynamic standing balance, and that's where I address my dynamic standing exercises. Does that help?
That's interesting. So it's all, there is a history behind it. Why PT usually did the lower extremity and OT usually did the upper extremity. There is a whole history behind it. Okay. And yeah, I think it's also very, now it's answering my question, like why OT always do the upper part and PT always do the
Yeah,
lower.
and OTs are supposed to be independent in ADLs.
Mhm.
Right? So what I also would strongly urge you is not just to accept things because that's what we tell you. 5 years down the road, what we tell you may be too old. So you have to be that lifelong learner. You have to question. You have to advocate for your patient and move the profession forward.
Okay. Thank you for your answer, Ms. Karen. So I would like to ask for the student. Is there a question for Ms. Karen? Yes, please. Please wait a minute for the mic.
Okay, hello, Miss Karen. So my question is, you use simulation repetition activity, right, for your treatment? What my question is, how do you manage your client to engage with your activity and like consistently doing your treatment without making them feel bored? Like sometimes people do the same activity every day and they will feel bored and they don't want to do it anymore. So how do you manage to make them feel engaging in your activity? Thank you.
You're welcome. So, what did I tell you all a little while ago? What's the word we OTs use to engage your client?
Therapeutic use of
Therapeutic use of self. Okay? Well, you also want to know what is fun for the patient. Now, with my patient, I took her up and downstairs and all that because she told me that, PT was taking too long and she needed to start moving. Her husband runs marathon. She's 72 and her husband's 72. And her husband still runs marathons. She needs to go places. She needs to do things. Okay? And in order to keep her motivated, in order to keep her going, I was addressing upper extremities and I was addressing lower extremities. And PT knew what I was doing, and PT was also doing the same things. So together, we were able to be very successful with her. Okay? But therapeutic use of self. So if a patient is interested in getting better and interested in getting back their functional skills, and you are constantly changing your protocol, what they're doing, and they see the benefits and they see that they're getting better, they're not going to get bored. But if you're going to have them just pick cones and just do cones and just sit under the edge of the bed and and another thing is you've got to make it challenging. In OTs, I think we use the term just right challenge, but in neurorehabilitation, it should be more than just right challenge. Because they need to see the challenge and then to learn from their experiences. And that's what's going to keep them motivated. Okay.
Actually, this also happen not only on our neurorehabilitation things, but also on the pediatric field. Because we use the same activities and sometimes the children get bored. And for the high function children, they can say like, oh no, I already did that. I want to do something else, something like that. So I think that's also very important. Our creativity is to make the activities more fun for the patient.
Yeah. And actually with OT, because we're engaging them in various occupations, we have more of a advantage in keeping them engaged. In my practice, very often I see patients who say, well, I'd rather do OT than go to PT. Because PT tends to do, again, I don't want to generalize, but a lot of the rote exercises.
Maybe because OT is more into like the activities, what they really do. Okay, is it answer your question? Okay, thank you. I will open Q&A session again, I think for one more question. And if you need to speak in Bahasa, it's okay, don't be shy. I will translate that for you. Kalau teman-teman sekalian ada yang mau ditanyakan, tapi masih bingung kira-kira pertanyaannya dalam bahasa Inggris seperti apa, boleh silakan ditanyakan dalam bahasa Indonesia, nanti saya akan bantu terjemahkan. Okay. Is there any other question? We do have two questions from Mr. Sakit and the other from the student. Which one, Pak? From the student? Okay. And maybe because this is the first year student, so I think they are still like wondering, oh, what is it, something like that. So maybe.
Yeah, and I fully understand, and I really applaud you all for even sitting through my lecture because as I was lecturing, I realized what I had prepared was pretty advanced.
But that's okay. I think this will be very insightful for the students. Okay.
Okay, thank you for the opportunity. My name is Domingo Alvarado, and I have made some notes about your presentations, and I love your presentation so much. Um, the presentation highlight about the occupational synthesis and meaningful engagement in dynamic world. And I love when I see your videos when you give the manual interventions. But as we know that now there's advantage in your or VR technology, um, and we know that Indonesia is in a low resources clinical setting. So what can we do as an OT in Indonesia when we know that we have a low resources? And how can we achieve the occupational synthesis while still satisfying the high intensity and repetitions demand?
Okay, so your question is, did you say something about virtual reality?
Yeah, so like as we know that there's so many technology that can help us in neuroplasticity.
Right.
But I love when you give the video that manual intervention is really good to do the repetition. So like can you give us motivations that OT in Indonesia also can give a best interventions with low resources clinical settings?
Yeah. And even in the US, even though we have virtual reality, I hear you all have a lab here, a virtual reality lab. In the universities, I've taught in the US, and University of Texas Medical Branch is a big university. We did not have a virtual reality lab. In fact, I had to arrange for a company to come and bring in their equipment to do a lab for us. Okay, so virtual reality, transmagnetic stimulation, infrared are all robotics, are all new technologies. We still do not have research on the efficacy of those technologies. However, because of my age and what, the time frame that I belong to, I did without a lot of this technology. You saw me use the ladder, you saw me use physio balls, right? And just beads or whatever it was. It is your knowledge and your understanding and your clinical reasoning that's going to help your client get to the finish line. It doesn't have to be technology, but you need to have a sound understanding on human movement and the human body and how the different systems work together. So focus on what is being taught in the classroom. And then as the time comes by, if you have virtual reality, see how virtual reality works. And you've got a lab, so you can actually get clients in and see what you can do in terms of simulated activities. Okay? And virtual reality is going to be simulated activities. Am I right about that? Yeah? Okay. And then you want to advance them to occupational engagement, real life settings. Does that help? Yeah. Okay.
I think there is another question or only one? Only one question, okay. Yeah, I think it's very important. And again, we talk about the therapeutic use of self. So it's more important of ourself, our knowledge, our capability, our communication skills, and so on, compared to the technology. Ourself is more important as a therapist than technology or resources that we have.
I fully agree. Don't get disadvantaged, don't get disillusioned because you don't have the equipment that the West has. We have a lot of that equipment very often. Sometimes I'm saying we have a lot, certain clinics have that equipment, and very often that equipment is not even used. Okay? So, but it is your knowledge, your skill set, that is going to help you become a good clinician.
So that way, if we only have a little resources, so we still can do the therapy.
And that's why I'm here in the global south, because I think sometimes all this literature that's coming out on robotics and all of that. But yes, there's robotics, they've got to do their research, it's got to be made available to the rest of the world. But in the meantime, we've got other skills that we can do, other evidence-based practices.
That's so inspiring. Thank you so much, Ms. Karen. Is it answer your question? Okay, thank you. And last, Mr. Sahid.
Okay, this is a great moment because today we meet occupational therapists from other countries of the global side. Um, what happened in here in Indonesia? We have a kind of sad story. Yeah, I have global certification, and some our OT friend in Indonesia OT also having certified in global, but we have sad story because our senior getting mad to us when we try to do uh, uh, doing strengthen about postural control, proximal. So, for example, when you doing down to step, so we do it also like that. So our senior will make this is physiotherapy, not occupational therapy. In short like that. So because in we 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 get some kind of different concept about OT. OT is always have to be activity based, like that. In senior mind. Yeah. So if just we do walking or sit to stand, it's not activity based. Okay. Uh, in my opinion, walking is part of functional mobility, right? This is OT tool, actually. Yeah. But yeah, because we are more, the, the I mean that we get met from the senior. So many OT junior were afraid to apply the kind of what you do. Yeah.
Thank you for that question because that has happened in the United States too, right? Yeah, it happened in the United States too. However, it is, that's why I'm saying educate yourself with knowledge and all of that. So you've got to fight back, you've got to push back. Your seniors and physios cannot draw your boundaries, right? Your patient is who you need to focus on. And if the patient needs to increase independence in areas, and it's, then you're doing what is right for the patient. Now, yeah, like I said, in the US too, there was a lot of pushback, because now I go back to 1993, where I remember once in a clinic that I was working, and this was a PT assistant, this wasn't even a PT. She called the director and said, well, Karen is doing something that she's not supposed to do. And the PT director, the director came down and said, exactly what I told you all. PTs can work on upper extremities if they have to train a client to hold a walker and walk. OTs cannot say you cannot do that because that's the PT scope of practice to teach them to move. And in the same token, if a patient has to stand up to pull their pants up, PT cannot tell you, no, you cannot work on it, or even an OT senior cannot tell you, no, you cannot do that. But times are changing. So, but and also I realized coming from Zimbabwe and now here, these cultures, there's a hierarchical system. So you have to be very careful about your interactions with your seniors and people above you, right? But you have to try to diplomatically do it because otherwise you're going to be forever limited in what OTs are going to do in this part of the world. And that change can come from education systems. So if you educate your students well in the use and lower extremity and upper extremity use, now they are in a better position to go out and do this. And the more they engage in whole body workouts, the more PTs and the seniors are going to realize, well, our way of looking at life is a little outdated, you know? And so I think it should start with the university and then policy. Because we have our licensing boards that kind of tell us what our scope of practice is. But I definitely know that OTs and PTs have same techniques that we utilize. But it's our that then decide what techniques, what evidence-based strategies are within our scope of practice. Okay, and I think I did not know you'll use the textbook Textures of Life by Jim Henry-Wilson.
Excuse me, what's the title?
Textures of Life. It's one of those first textbooks that, in the introductory textbooks, they clearly tell you there of what makes interventions OT and what makes interventions belong to a different discipline. And it's very, I don't have it with me right here, but I can copy that chapter and send it to you. But it's the book is Textures of Life, and of course,
I think it's one of the challenges that we need to face and the hierarchy of things and so on. Yeah. And what we do today is how we will face the challenges.
yeah, exactly.
That's the the important part when we meet OT from other country is we will have different point of view, and yeah, so this made me yeah always happy when someone other OT from other country come and visit our university. So yeah, we will have a lot of
Yes. Yeah. And also, I think what I should say is in the US too, when you talk about the CEO of business country. And then we have the more contemporary OTs like these who have pushed the limits, right? And so, but in the end, we want our profession to grow, and we do not want to be limited to only teaching compensatory techniques and use of sockets and dressing sticks and all of that, because we can work on recovery. And I think that's really what the take-home message of this is, because when you've had a stroke, you want people to recover and not kind of live through life, or what's the word? Live through life disease.
Okay, that's interesting. Is that answer your question, Mr. Said? Okay, thank you. I think we still have a lot of things to ask you, but unfortunately, we come to the end of our session today. And to close today's um, lecture, I would like to read the summary of your presentation today. Okay, so we have learned that stroke recovery is not only about restoring movement, but also about harnessing neuroplasticity to reconnect the mind, body, and meaningful occupations. Today's lecture highlighted the importance of neuroplasticity, which is the brain's ability to adapt to its environment and reorganize itself following injury. The brain ultimately responds to function. Therefore, rehabilitation should focus not only on biomechanical recovery, but also on meaningful functional participation in everyday life. We learned that recovery is supported by critical information, enriched environments, and opportunities for active engagement that promote positive adaptation. The lecture also emphasized the critical role of interprofessional collaboration in maximizing patient outcomes. To achieve true occupational synthesis, the skills learned during rehabilitation must be generalizable and transferable to real-life situations. Finally, the therapeutic use of self by occupational therapists plays a vital role in motivating and empowering individuals throughout their recovery journey. May I speak in Bahasa as well to state the summary of this lecture? Walaupun ini adalah pertama kalinya mungkin teman-teman mendengar terminologi-terminologi yang mana wajar karena masih dalam tahun pertama untuk pembelajaran, tapi percayalah bahwa materi yang disampaikan oleh Miss Karen hari ini sangat-sangat bermanfaat untuk di kemudian hari, baik ketika nanti praktek klinik ataupun pada saat menjadi seorang terapis okupasi. Kita telah sampai di penghujung kuliah umum hari ini. Kita telah belajar bahwa pemulihan pasca stroke bukan hanya tentang mengembalikan kemampuan gerak, tapi juga tentang memanfaatkan neuroplastisitas untuk kembali menghubungkan pikiran, tubuh, dan aktivitas bermakna dalam kehidupan sehari-hari. Kuliah hari ini menyoroti pentingnya neuroplastisitas, yaitu kemampuan otak untuk beradaptasi dengan lingkungannya, melakukan reorganisasi setelah mengalami cedera. Pada dasarnya otak memahami fungsi. Oleh karena itu, rehabilitasi peningkatan partisipasi fungsional yang bermakna dalam kehidupan sehari-hari juga harus dilakukan untuk proses pemulihan dari pasien. Alright, thank you once again to Ms. Karen for sharing your valuable insights and inspiring us to continue bridging the mind, body, and occupations in our clinical practice. So once again, please give big appreciation for Ms. Karen for